and welcome to tonight's webinar, Price Transparency in Healthcare, an important legislation that every medical student, resident, fellow, and physician should know, that is being presented by Dr. Chandra Bandagula. He is the founding ACGME designated institutional official and director of graduate medical education for North Alabama Medical Center, LifePoint Health in Florence, Alabama. My name is Jennifer Price, and I am SMA's Director of Education. And before we begin, I would just like to mention a couple of housekeeping details. Please use the raise hand feature and we will unmute you so that you may ask your questions. We will also be monitoring the chat feature, and any questions asked there will be passed along to Dr. Bandagula. And then within the next week, you will receive an email from customer service at sma.org that provides details on how to claim your CME credit for this webinar. And we will now begin the presentation. Dr. Bandagula, I will turn it over to you.
Okay. Thank you, Jennifer. Thanks for that wonderful introduction. And good evening, everyone. Good evening, Southern Medical Association members. And I'm Dr. Bandagula, the DIO at North Alabama Medical Center. I'm very passionate about this topic, price transparency in healthcare, the legislation and how it's being taken in the industry so far. So the topic, price transparency in healthcare, an important legislation that every medical student, resident, fellow, and physician should know. So today our agenda is going to be introduction, legislation of 3 price transparency mandates, consequences and penalties of non-compliance, price transparency stakeholders, how it's affecting them, and NAMC price transparency, and summary and recap of the. So if you see here, we have all these 4 great organizations that have been instrumental in bringing this legislation. You know, you see this here: Department of Labor, Centers for Medicare and Medicaid Services, Health and Human Services, and Department of the Treasury. So I want you to, this is, right now we are talking about 2021, the transparency in 2021. But if you look at here on the screen, the price transparency existed 100 years ago. So you see at the paper here on top, where the newspaper, this was 100 years ago. This was published in 1921, May 21st. So it's a Florence Daily News. This is where our hospital is located. Our ECM hospital is what you see behind. And in the red line where it's marked in red, it says, "Our hospital, a great and useful institution for the use of all classes of people." So I underlined all classes of people, meaning that, you know, we talk more about the equity and everything right now. But, you know, looking at 100 years back, they were proud to say that we cover all classes of people. And if you see here, these are the prices that they have compared between different hospitals in the locality. And since it's not visible on the newspaper, so I tried to put it in a slide format so that it's easy for everybody to look at it. So I just want to go through this. You know, this is Eliza Coffey Memorial Hospital, which is current North Alabama Medical Center, and Belmont Sheffield Hospital close to us, and Decatur, Huntsville Infirmary, Baptist Memorial, Memphis, Tennessee, and St. Vincent's, Birmingham here. So if you look at, they gave the prices for private room, weekly, double room, weekly, wards, operating room, x-rays, doctor fee, and x-rays. If you look at the prices, they're almost very similar prices. So even if you look at in Baptist Memorial, it's 25. So Huntsville is 25. Decatur is 20. So very close to what they were offering in different cities. So, but which is completely opposite to what we have now. A price in NAMC will be completely different than what we have in Huntsville Hospital or what we have in St. Vincent's Birmingham. So kudos to these, the Florence News, which covered this price transparency, and we're proud of saving this newspaper. So why transparency in healthcare now? So who are being affected, right? Consumers. So 150 million Americans are either underinsured or uninsured. Underinsured, I mean to say they could be either high deductible or their services may not have been covered, all are not covered. And if you see, 67% of personal bankruptcies are due to medical debts. 1 in 5 delays seeking care due to unknown or fear of costs. And there's a lot of variation in prices within the region. Like, one hospital charges $750, other may charge $1,500 within the same place. So on the employer side, also there are a lot of problems. Out-of-pocket costs increase for consumers, for the employees, and the premiums are also increased, and the employer are not able to offer them. That's why they offer either high deductible, and also they depend on the third parties to do the negotiation. So there's no transparency in the third party negotiation. And these third parties are negotiating at a very high rates. So which is not good for the employer. So looking at all these, in 2020, the President Trump, he has brought the executive order to, he said President Trump is putting American patients first by making healthcare more transparent. So he also said we should also require drug companies, insurance companies, and hospitals to disclose real prices to foster competition and bring down costs. So this was on June 24, 2019. And if you look at on the other side of the spectrum, the President Biden, he doubled down on same thing. So he said, he also gave an executive order requiring all hospitals to comply with price transparency rule and directed Health and Human Services to support hospital price transparency exactly after 2 years. So which is a good sign. So this number one is we're talking about the CMS price transparency, hospital transparency. So starting January 1st, 2021, the CMS requires all hospitals in the US, except for the VA, TRICARE, or Indian Health Services, to publish their standard charges in both a machine-readable file and in a consumer-friendly manner. Actually, this rule was opposed by stakeholders and was also upheld by the Judge Nichols. And later, again, the AMA and American Hospital Association again fought against it, but Supreme Court turned it down. So then it became the reality. So the CMS requires a single machine-readable file that contains all types of standard charges for all the items and services provided by that hospital, which is the Charge Master. So the format of the file they require is EIN with a hospital name and standard charges with JSON, XML, or CSV. This is the format they want everybody to publish. So for the doctors, it's important because the CMS said only include the professional fee if the physicians are employed by the hospital. If they are non-employed by the hospital or consultants, they don't have to publish the physician charges. And a consumer-friendly list of charges. This is called shoppable services. Shoppable meaning a patient should be able to schedule a service before seeking care. So within this shoppable services, there are two things actually. So the CMS has given 70 mandatory services, and they asked hospitals to pick 200.
Hey, listening to a webinar. I hope I can stay in it. Okay.
So the additional 230, they gave option to the hospitals to publish. So in a total of 300, so 70 plus 230, they should have 300 shoppable services. There are exceptions. If there are less than 70 mandatory services provided by that hospital, they should say not provided by them and give additional services which could make up for this 300 services. So the exception 3 is if there are less than 70 mandatory services and also less than 230 additional services, because the hospital may be small or a critical access hospital or a rural hospital. So they can provide less than 300 shoppable services. So here, if you look at what is a charge master, what are the 5 items that the CMS requires? So it's a gross charges, discounted cash prices, payer specific negotiated charges, de-identified minimum negotiated charge, de-identified maximum negotiated charge, description of each item service, and any code that the hospital uses, plus whether it's an inpatient or an outpatient. And also, again, on the same note, the shoppable service is also same, discounted cash price, gross charges. This could be the difference between these two is either one, you can give one of them. And payer specific negotiated charges, de-identified minimum and maximum. Same description of the item service plus the codes. If somebody doesn't want to give a shoppable services as an MRF as a machine readable file, the CMS gave an alternative like patient estimator tool they can give instead of that. So they have to provide the same 70 with additional 230 services. And consumers will be able to obtain the estimate of what they are obligated to pay. And this should be promptly displayed on a hospital website. Plus, it should be accessible to the public with no charge. That's number one. No need to register or establish a user account or password, meaning that they should be able to see those prices without any identifiers. So looking at this is a hospital, we are looking at the machine readable file. As I said, 5 standard charges. So here we are seeing the gross charge. So you see the procedure, you see the type of the code, what's the number of the code, and description of that service. So this is a gross charge, meaning that this is a ticket item where the hospital charges for the service. And these are all the insurance companies, how they negotiate with the hospital. So 7759 is what's the gross charge. And these are the prices that the insurance companies have negotiated with. And you can see here the minimum negotiated price, the lowest of all the prices. And it doesn't give which insurance is it. That's what it is, minimum negotiated with the de-identified. And here maximum negotiated and discounted cash price. So if you can see here in this data, there's an error here. So if you see here, the maximum negotiated price is 11,600 or 11,000, actually 11,870. But if you see here, they have given 7,759, which is error. I've seen many providers who have published this type of data. So that's why I picked this, the wrong file. So these type of errors we see in the data. So another one, this is like a shoppable services. So this is a major hip and knee replacement without MCC. So this is one hospital group in Ohio, the Ohio Health. So Central Ohio in Columbus. If you look at the hospitals within that health system, these are all the 8 hospitals that they have. And you can see how different their prices are within the same system. So if you see the blue ones, which is a gross price, you can see how variable these prices are. And same way, the cash prices are also variable. And you can see the minimum negotiated, you can see the maximum negotiated. So within the same system, you see such a difference. So this is what is going to help the future, patients or anybody to compare prices. So when they see this type of information, they know that they can go either to Berger Hospital or Shelby Hospital or Brady Memorial instead of going to James Cancer or these 2 other hospitals. So this is very important information for the consumers, for the employers, and also for physicians like us, medical students, residents, fellows, or any physician, because this is where you will recommend the patient to go. So you will tell them to go to a place where the charges are low. Of course, you also consider quality, but most of the time, prices are very important. So what happens if the hospitals are non-compliant? What CMS is going to do? So the non-compliance penalty. So if you see at the bottom, for hospitals that do not comply, they issue a warning notice, request a corrective action plan, impose a civil monetary penalty, and publicize the penalty on a CMS website. So as of June 2022, CMS has issued 352 warning notices and 157 corrective action plans request to hospital. So how are the penalties calculated? So in 2021, any hospital that was non-compliant, they were charged $300 per day, no matter if their hospital has 10 beds, 20 beds, 1,000 beds. It was uniform across it. But this year, CMS changed that. For any hospital that's less than 30 beds, 30 or 30 beds, it's just $300 per day. But beds greater than 30, it's going to be $10 per bed per day, not exceeding 5,500. For example, if a hospital has 550 beds and they're non-compliant for 1 year, their penalty will be $2 million. And if they are $300 and non-compliant for 1 year, it's going to be $107,000. So this is pretty expensive for the bigger hospitals. And recently, 2 hospitals were penalized. So that's in Atlanta, where I am right now. So Northside Hospital, Atlanta. So they were penalized for $883,000. And Northside Hospital, Cherokee, it's $214,320 and $320 was their penalty. So the CMS considered not only 2022 penalty, but they also recovered from 2021. So that's the key here. So the second one of these one is called the No Surprises Act. No Surprises Act, as you know, previously many patients were struggling with this. If you are going into an emergency room, your ER physician may not be your in-network provider. He may be contracted or an out-of-network provider, and you get a bill where your out-of-pocket costs are very high. So to prevent that, the government has come up with the No Surprises Act as part of the Consolidated Appropriations Act 2021. So it has brought to establish protections for consumers related to surprise billing and transparency in healthcare. So this was passed, this got into effect on January 1, 2022. So what does it have? So surprise bill for most, so what you should avoid. Surprise bills for most emergency services, including out-of-network services. Out-of-network costs for most emergency and some non-emergency services, like patients cannot be charged more than what they would be in network. So whether they are out-of-network or anything, they should be charged same as in network. Out-of-network charges for additional services like anesthesiology or radiology, resulting from a patient's visit to an in-network visit. Same like emergency, what I was mentioning. So they have to do similarly, they cannot charge out-of-network price. They should charge just in-network. And there's a new law. So they also came up with a new provider payer arbitration process for out-of-network providers. So if there is any discrepancy, if there is any contradiction or anything, they can do an arbitration by a third party. So there are some rules for that. So, and if you look at any hospital, they have published this No Surprise Act bill, the information about this on their website, so that it should be useful for the patients. So what is the penalty for not publishing this No Surprise Act is $10,000. For example, if any healthcare provider violates the law unknowingly, they can avoid penalties by withdrawing the surprise bill within 30 days. And coming to the third transparency law, which is transparency in coverage rule. So what it means is transparency for insurance and health plans. So we talked about transparency for hospitals, and this is for insurance and health plans. So this went into effect on July 1st, 2022. So this rule requires insurance companies like ASOs and individual and employer health plans to post in-network and out-of-network rates that they negotiate with providers. So this also has ban on gall class. So if you know what a gall class means, that, if whatever you negotiate with the provider, you should not disclose it. So previously it was like that, but the government, the law was passed that, this is no more eligible, or they cannot do anything or have the gag clause in their negotiations. So, and also insurer and agent broker compensation disclosure was also implemented, plus new MLR ratio calculation was also changed. So what is a possible penalty? It's a penalty of 100 per day for each violation and for each individual affected by the violation. So there is a like a 3 years plan for this. So on July 2021, so the health insurance issuers must post machine readable files containing the following rates for all covered items and services between the plan or issuer. So similar to what we had in the hospital price transparency, we had only one machine readable file, but here they have 3 machine readable files. So in-network providers negotiated rates for all covered items and services. And historical data that shows both billed and allowed amounts for all covered items and services set by out-of-network providers. And negotiated rates and historical net prices for in-network prescription drugs. This is delayed until further notice. So these two are now in effect. And in January 2023, each insurance have to publish a personalized out-of-pocket estimation tool for 500 shoppable services. The CMS has published the 500 shoppable services. So it will be in effect from January 2023. And in January 2024, the same, so instead of 500, they have to give out-of-pocket estimation for all items and services. If it is 30,000, 40,000, 50,000, they have to give everything in the estimated tool. So compliance related, right? So only 14% of hospitals comply with price transparency. That's the survey finds, according to Becker's Healthcare. Different researchers have published different numbers, but it depends how they are taking the numbers, whether they have taken all the hospitals and trying to do the compliance testing, or are they taking 1,000, or they taking 100 as a sample. So that's very variable. So that's why this number is very variable. So it could be like, for some, it could be 6%, some it could be 30%, depending on how they take, what hospitals they consider. So this one is very interesting. As of September 20th, a bigger health system, it can be penalized up to 100 millions if CMS goes after the system as they are non-compliant. So I know you must be knowing the bigger system in this country. So they are non-compliant, and based on the calculation from last year plus this year, based on the number of beds, they will be penalized at least $100 million. So I feel price transparency is public health. So we should consider it very serious. So who are all affected? So who are the stakeholders in price transparency? So the number one stakeholder is CMS. So because they make the laws, they pay for the providers. So they also check hospitals' compliance and also insurance compliance, and they penalize non-compliant ones and create policies. That's CMS role. So how about hospitals? So hospitals, number one is, they have to publish their prices. So they have to meet compliance with the CMS requirements, and they have to empower patients by publishing their data so that they can attract more patients, and Because right now, many patients are afraid to come to the hospital because of lack of information. At least with the transparent information, they can attract more patients. And also, these hospitals with this information right now, they can compare how their competitors in the same region have negotiated with the insurance companies. For example, Birmingham, UAB has negotiated with Blue Cross Blue Shield of Alabama and Cigna or Aetna. In same way, Baptist Health can also compare the prices at Blue Cross, with UAB, how UAB has negotiated with Blue Cross or other insurances. If Baptist Health feels that they are given a bad deal, so they can negotiate with the insurance company next year, saying that, we also want similar negotiation. Previously, they didn't have this information, but now they have this information, so they can renegotiate contracts at a better rate. How about consumers and patients? This is very important for the consumers, the patient. So they can visit the hospital and websites and see the data. They can also see the aggregator sites for shopping. So because they are shopping the services, they can look at some aggregators and find different prices in that locality. And sometimes they feel that it's not worth for them to have insurance, then avoid insurance. They don't take insurance, but they want to pay by cash, because if the discounted cash pay is low, they want to pay that instead of paying insurance. So it depends on, this is something that's going towards. If you look at some of these millennials and those who feel that we are healthy, we don't need insurance. So those type of people, they may try to take catastrophic insurance for any major accident and try to pay for, out of pocket when needed. How about the physicians and, healthcare professionals, anybody, or nursing professionals or anybody. So for doctors, it's a point of care pricing conversation. If you know the price of this hospital, for example, a patient is coming to your clinic and he needs an MRI. You suggest an MRI for that patient. You can guide that patient if you know the information. For example, hospital A charges $1,000, and there's an imaging center in the local where they only charge $500, or there's another hospital that charges $2,000. So you will tell the patient that, because of the information that you have, you'll tell the patient you want to go to 500, where they charge 500, because you want to save money for your patient. So that's what empowers you to take better care of your patient. And like I said, refer to low-cost hospitals. And also it increases patient confidence and also patient-doctor relationship. If you look at patient advocacy groups, so they are also similar. So their role is to educate patients and also support fair prices. And they build trust in the consumers. Employers, because employers are able to see the prices now, they are going to avoid the third parties, or they don't want to go with any insurance. So they say that, okay, I can contract directly with the provider. I have 100 services. I can ask this hospital, I can check who is offering better prices to me. So they can, that will be where self-insured employers may move towards. So the direct contracts are happening right now. And they'll also incentivize their employees to choose low-cost providers, because they have the data about the low-cost providers, and they can incentivize them to go there, because they want the employees not to waste their money, and they can save that money for something else. And if you look at the insurance companies, so they're also opposite to hospitals. In a way, hospitals know how the negotiation happens. Insurance companies will also look at how the hospitals are negotiating with different insurance companies. So now, Cigna or Aetna will look at how these hospitals, UAB or Baptist Health, are negotiating with these insurance companies. So if they feel that Blue Cross Blue Shield is paying a lot low than what the insurance companies are paying them, so they can go back to the provider and renegotiate their next year contracts. So it's in both ways, hospitals and also insurance companies. It's a double-edged sword. So insurance companies can also provide better tools now because of the data is out, And they can incentivize to shop for low-cost services because they know the data now. They know the hospital who is providing low cost. So they can incentivize them to go there. And as MLR, there's a law because of the MLR, they can, previously, they were counted, whatever the benefit that they have given to the consumers or their covered patients, that money, whatever that saving was considered as administrative cost. But now, according to this transparency law, that saving will go into the patient side of the payment. So that's why it will be like a reimbursement for a patient. So it won't be counted as an administrative cost for the insurance company. That's a very good incentive for the insurance companies. So insurance companies also, what's happening is how they are going to be affected, because when the employers knows that the provider prices and they can negotiate themselves, they can avoid this insurance. So insurance is risk losing employers because the employers are already negotiating directly. And if you look at the pharmaceutical companies, so they can compare drug pricing and they can avoid pharmacy benefit managers who are the negotiators and can contract directly with the providers. And if you look at the researchers and academicians, because the data is available, they can do research and publish findings and recommend policies and advocate for fair prices. And media side, because the data is available, media also can create awareness among the patients and Americans, and they can bring the prices to the mainstream. They can create host talks and also pressure providers to publish the prices. And the last one is the tech innovators, where these people will collect data from all these hospitals, aggregate them, and create consumer-friendly tools, and also make hospitals compliant because of the compliance tools. They drive the consumerism and make the patients save the costs. So think about this, like currently we have Priceline, where you go and bid for the services, right? It will show you the low-cost providers within that, the airlines or hotels or anything. Similarly, you can see in the future, it's going to be, you can see those type of arrangements in the tools, actually, in the on the marketplaces. So I won't say all of them will be on the marketplace, because the emergency services can never be like that. Still, you need them to be, you don't know them, but at least the 70% of whatever the shoppable services can be disrupted by using these technologies. And also, for somebody coming to the hospital, having that information, somebody is admitted to the hospital, but at least they know how much they are going to incur, because that data is also there, how much it costs for them. It's like a 40,000, 30,000 in advance, if there's a historical information about a cash price. So they know ahead of time that they can pay, instead of waiting for the hospital insurance companies to send them the bill. So our lovely residents here. So we have embraced price transparency and also incorporated into cost-conscious care into our residency curriculum. Myself and our Dr. Chahal is our program director. So he's also very particular about the cost of care. So, and our residents are also part of these value-based programs like, co-management, and they know the prices. They're also used to now to look at when they are ordering something, they look at the price now. So that's I think we hope this will be implemented everywhere. All the programs would utilize this price transparency information and educate all the residents, fellows, and medical students to follow these guidelines, so that they can help their patients. So in summary, so So we'll wrap up Hospital Price Transparency, No Surprises Act, and Transparency in Coverage. These are the three laws we looked at. So this is effective from January 1, 22. This is January 1, 2020. So sorry, Transparency Hospital is 2021, Surprise 2022, and July 1st, 2020. What is the frequency update? So CMS wants the hospital and the insurance companies to update the files. So hospitals are mandated to update at least once a year, but insurance companies should update every month because they will be giving the live data to the patients. So they have to publish every month. They have to update every month, which is a huge task for them. So what are the penalties we discussed here? Less than 30 beds, 30 per day, more than 30 beds, 10 beds, 10 per bed per day, not exceeding 5,500. No Surprises Act is 10,000, and Transparency in Coverage is $100 per each violation per case. And this is the format, machine readable file, and they have three files. Codes will be similar: CPT, EPICS, DRG, NDC, and here also all those codes for various. And the prices: gross price, discount, payer specific, de-identified, minimum and maximum. And here it's in-network negotiated rate, out-of-network allowed amounts, and historical out-of-network bill charges. And finally, these two formats, hospital machine readable file of Charge Master data and 300 Shoppable Services or a patient estimator tool. No Surprises Act, same thing, like out-of-network should be similar. Out-of-network and in-network should be at the same price. And even emergency or non-emergency services should be the same. And any additional services like anesthesia or radiology, they should also be charged at the same price. And Transparency in Coverage: in-network providers negotiated rates, out-of-network billed and both covered allowable amounts. And 2023, 500 items are going to be, they should publish in a estimator tool, and 2024 onwards, all items and services. And the key takeaways from this, number one is understanding the legislation towards price transparency in healthcare, how price transparency is going to transform the US healthcare system, and why do you need to understand price transparency? How will it help to deliver to your patients at low cost? So real transparency only comes when the cost, quality, provider, location, time, and outcomes are known in advance to a patient. So I mean, if they know the cost is $500, the quality is better, my doctor is X who is going to do it, and I'm going to be doing in either hospital or I'm going to do it outpatient based, and I'm going to do it at 10 o'clock in the morning. And the outcomes for the services or outcomes for my doctor or the hospitals are better than at the net, better than other providers, or even at the at par level, at par with other hospitals in the nation. That's what the patient need to know to be completely transparent. So I think this is where we'll go in the future. This is in the future, like 3 to 4 years. I envision that we will see these type of transparency. So that's the end of my presentation.
And it was a wonderful one. And we thank you so much for sharing this information with us. And if there are questions, I see one has popped up in the chat, and that is, how do you suggest the awareness on price transparency can be increased among practicing physicians?
So one of the things is, like I said, education is key. One. Second thing is, practicing physicians, if it is, community physicians versus academic physicians. If it is academic physicians, like, every hospital, every residency program discussing or doing like grand rounds or intentionally teaching this topic to the residents or fellows, and also engaging all the faculty members in price transparency education. So that helps the provider. Also, for the community providers, it is, they can, American Medical Association, they can do some education. American Hospital Association can do that. Plus, they can attend some CMEs like now what we are doing. And they can also, and everywhere we are writing articles on this, so they can look at these articles to know the cost and how to guide their patients. Also, there could be aggregator sites where they can see these prices and recommend to their patients.
Okay, if anyone has questions, you can raise your hand. We have another question. In theory, these measures could drive cash prices down for patients and charge prices down for hospitals, in parentheses, competition. But what would prevent a price spiral upward now that all hospitals will know what their competitors are charging and actually have negotiated to receive from insurance companies?
So, I mean, that's why one of the reason, the compliance is not there. Many hospitals are afraid to publish their data because they know that the minute their prices are out, insurance companies, their competitors will be looking at them. So, when everybody publishes this data, this is going to be like a competition and prices may come down. But, if you look at some of the hospitals, like, academic centers where they have transplants are different. So there, I don't think they're going to come down on their prices, or it's easy for them to say, because that's like, you cannot predict how much it's going to be costing them emergencies. But so, I mean, it's a very, very good question. It's going to be a challenging thing for hospitals also. We can, now we can say hospitals, whenever they're having low, operating margins are low, the practice was to increase their charge master prices. So nobody was looking at how they were increasing their prices. Now there is a mechanism to check them. So it will be a tough thing for a hospital because, I compared last year to this year prices. So some of them have increased their prices, but some have kept it constant. So now, every year when you publish the data, people are going to ask you, why did you increase the prices? But, with all this COVID and everything, the cost is going up. So how are the providers or physicians going to, provide the care at the same cost or even lower than the previous cost? So that's a question.
Dr. Pasha has his hand raised. Dr. Pasha, I can ask to unmute and you may ask, or I am happy to ask the question in the chat.
Thank you, Jennifer. Hello, Dr. Bondugula. My question was, what would be the barriers that we would or the CMS would anticipate when implementing this price transparency?
So you may, good question, Dr. Pasha. CMS is like, the challenges is like, right now, all the hospitals are not publishing the data in the same format because CMS in the first place did not give a proper format. So they have given open, like they have given some guidance, but they didn't say that you have to publish the data in this format only, like they did for the insurance companies, but they didn't do for the hospitals. So that's why if you look at all the hospitals, there's a lot of variation. If you go to each and every hospital, so the data is in a different format. So first thing is having the data in this, one format which is uniform would help CMS to audit them. And two, since the data is not clean, the hospitals, the CFOs, some of the CFOs are, in the billing, they don't know how their data is. There's a lot of cleanup has to happen in the charge master. So when we analyze many of the hospitals' charge masters, was, 20 years data, which has not been cleaned. And every time they're using part of that charge master to negotiate with the insurance companies. So that is a big challenge for the hospitals to meet the CMS requirements. So, and also like, until the CMS comes up with, real penalties like they did for Atlanta hospitals, then the hospitals may not be willing to, completely do the right job. Plus, they also gave an option in the estimator tool. So estimator tool, patients or anybody cannot find the answers right, because when you enter, every time it will ask you for something else. So by the time you get to the right answer, you are already lost to know that information. You lose interest. But if there is a machine readable file with all the information in one file, somebody can pull that file and say that, okay, this is the price of this one. So even for the CMS also, it's easy to identify them. So I think CMS has to come up with few more guidelines, a clarity. They should say, okay, I'm staying in Maryland. I'm at the CMS office in Maryland. I want to see the hospital in UAB. I should be able to see in a click of my thing, I should be able to see the price, which is not possible right now. It may take some time, but that's the best way. I think that will be the future. So where I'll sit in the CMS office and the CMS admin, somebody in the CMS office will be just checking, or a Medicare administrative contractor, they'll be checking the price. So that level of disruption has to happen to get to that level, or to make it more to remove those barriers.
Thank you very much, Dr. Bondugula. Excellent webinar, very good information. Thank you.
Thank you.
We have another question in the chat. How does price transparency affect a practitioner practicing independently?
So, two things. If it is a hospital price transparency thing, so the law does not, so for example, it depends. If they are community physicians, they are practicing on their own, and they are not employed by a hospital. So then they don't come under this price transparency law. So they don't have to publish their data. But somebody who is employed by the hospital has to publish the physician prices, or the the professional fees. On the other side, in the insurance side of it, transparency, the insurances have to publish all their negotiated prices, including even if they're helping the employers. So they're going to negotiate with the hospitals, they're negotiating with the ambulatory surgery centers, post-acute care services, physicians, everybody. So then that's where the physicians also get into the transparency. So hospital side, they're not affected that much side, but from the insurance side, they are being affected. So tomorrow, the data from hospitals, the data from insurance companies, if you merge those two using the provider's number, you can match them or map them. Then that is where the community providers will be able to impact the price transparency, or being impacted with the price transparency. So they will know that information, and then they can guide their patients who come to their clinics. And also they can also look into the hospital's website and see who is charging what, and where they can send their patients.
Another question in the chat is, do you think at some point hospitals will provide patients with quotes before service?
Yes. So if you look at the discounted cash price, so that is one way of presenting it. So some of the providers who are very proactive. They're already coming up with some prices in advance. So they are giving them some certain services like shoppable service. Okay, MRIs, CT scans, ultrasounds, colonoscopy, or these type of services. They're already giving the cash price. If you pay cash, they're going to give you a discount of 40%, 60% like that. So they're already providing that kind of information. Hospitals are doing. And some hospitals who are very conscious about those things, they're not yet there. I think in future, this is going to be the thing. Every hospital is going to openly publish their prices, because if they open their prices, they can see more volume coming to them. So currently 1 in 5 patients is not coming to the hospital or a provider. So that gap can be fixed if you open the prices. So patients won't, because if you see the mentality of a consumer, if they know the price, they won't worry. They don't get surprised, or they're not afraid to go there. But if they're afraid to say that what is the price, so that's why they're not. If hospitals are going to publish this, provide this information in advance, patients are going to definitely come to the hospitals, and I think it will be it will be in soon, like I would say at least 3 to 4 years, we may see that kind of information coming out. And if you see some of the hospitals already, they have done that. And there are some surgery centers who have already published their prices. They take only cash. They're not offering any, they don't take insurance. They're only taking cash price. So I think some of the hospitals may turn to that kind of a service in future, because you get the money upfront. You don't have to wait for the insurance companies to pay, or you don't have to wait for pre-authorization and all these things. So that will be comfortable for a hospital. So maybe smaller hospitals can do that. They can try that. They can be innovative with that. And insurance companies also, the transparency law towards the insurance companies, so they have to provide in advance, cost of care in advance. So they have delayed it till 2022 December, as per the transparency law, but it's going to come in 2022 December.
Are there any other questions? I don't see any additional questions in the chat, but so I will conclude tonight's session. Dr. Bandagula, once again, thank you for an absolutely outstanding presentation. And for our audience this evening, please check your email. You will receive a notice from customer service at sma.org within the next week or so regarding instruction on how to claim your CME credit for tonight's webinar. And I encourage you also to visit sma.org for information on some of our upcoming events, including October's webinar on October 11th, when Dr. David Netcher will present on common tendinopathies, and also SMA's annual scientific assembly taking place October 28th through 30th in Pigeon Forge, Tennessee. We would love to see you all there. And with that, if there is nothing else, I will conclude tonight's webinar.
So Jennifer, can I just give you remarks? So, thank you, Jennifer. Thank you, SMA, and Dr. Sangeeta and Isaac. So for introducing me to SMA for this transparency topic. If anyone has a question about the transparency or the law, any 3 laws or anything about the price transparency, feel free to reach out to me at the email given at the bottom. So I'll be happy to discuss. If you have any questions, feel free to share.
Thank you again, and everyone, I hope everyone has a wonderful evening.
Thank you all.
Thank you.
Thank you so much, Jennifer. Appreciate it.
It was wonderful. Thank you so much. Sangeeta, thank you. I was messaging her through saying I just couldn't thank her enough for connecting us. This was excellent.
Thank you so much. Thank you so much. This is great. So yeah, thanks for your time, Jennifer. It was a pleasure working with you. So if there's anything, let me know how I can be helpful to you.
Absolutely. Thank you so much.
Thank you.
Sangeeta, I guess I'll see you in Pigeon Forge.
Yes, I'll be there. Thank you, Dr.